I try to present our view to treat complex iliac artery lesion, task classification again. Complex lesion commonly classified task C and D by task classification and historically treated by open repair. Task for iliac lesion is heterogeneous and not reflect our real daily practice in vascular surgery. The guideline of European Society of Vascular Surgery represent the real practice for isolated iliac lesion. We do endovascular surgery. Good treatment for complex iliac lesion start by a good quality of CTA to assess inflow, outflow, calcification, thrombus, risk of rupture, extension for the iliac or common femoral artery. For isolated iliac lesion, we treat all patients by outpatient, ultrasound-guided puncture for the artery, and closure device. For common iliac approach, we start by ipsilateral approach retrograde. Doesn't work, we do contralateral approach, and if we have calcification in the other femoral artery, we do brachial approach. For external iliac artery, all our approach is antegrade from other side or from brachial artery. For ostial lesion, bilateral approach or brachial approach to reduce the risk of dissection and to provide better pushability. This is from Museum, total occlusion of common iliac artery treated by crossover and stenting. To cross the lesion, we can use soft or stiff wire, O35 or O18, assisted by a directional catheter or supported catheter. If failed, it is possible to use a dedicated re-entry device, Outback or Pioneer. No technique seemed to provide any patency advantage. Question of personal preference and comfort. Question, primary stenting versus selective stenting. In this paper from Abu Rahma, primary stenting for long lesion provide a high technical success and patency rate. Meta-analysis for the same subject, long-term primary patency for patient receiving primary stenting, 92% versus 82% for selective stenting. Which stent for common iliac artery, balloon expandable covered stent or bare metal stent? Our preference were to balloon expandable covered stent in this area of artery. 𝗂𝗏 study show 5-year results of 𝗂𝗏, significantly higher patency rate and survival for covered stent in complex lesion. Another recent paper showed no difference between covered and uncovered balloon expandable stent, but our preference, despite a little paper, to covered stent. In case of unilateral ostial lesion without plaque in the wall of the aorta, we stent only the lesion and not the contralateral iliac. For external iliac artery, our preference are self-expandable stent and covered self-expandable stent via ban for the patency and reduced TLR. a case of total occlusion of external iliac artery treated by brachial approach, recanalization, and stenting by VIABAN and control. For internal iliac artery, if the origin is patent, catheterism of internal iliac artery, ballooning, and over the origin of the internal iliac artery, self-expandable stent. We avoid overlapping stenting, overlap the stent over the origin of internal iliac artery. If internal iliac artery is occluded, VIABAN self-expandable stent. In case of extension of lesion to common femoral artery, our view is hybrid surgery, hybrid technique, under tracheotomy or bypass for the common femoral artery and angioplasty of the iliac artery. We can do angioplasty of one side of iliac and a crossover if we have a total occlusion of common and external iliac artery. Some paper for patency, excellent patency for hybrid technique, angioplasty of iliac and open surgery for common femoral artery. This is a new paper from Marseille for the endovascular treatment of common femoral artery, the subject of the next presentation. The perioperative mortality is not in favor of endovascular repair. Perioperative morbidity show advantage for endovascular repair, and the long-term primary patency rate was greater after open surgical repair. Indication and optimal endovascular is unknown. And same time, we can do both common and iliac artery endovascular repair. In this case, date of birth 39, very high risk for hybrid surgery, never anesthesia. We puncture profunda and we do safari from profunda and other side to recanalize total left iliac artery. In this case, it's possible to do recanalization. If we have a plaque from iliac to the wall of the aorta, we move for the 𝗖𝗋 technique. And for this presentation, open surgery. In conclusion, endovascular first for most iliac CTOs with excellent midterm results, vascular access from multiple sites to facilitate stent placement. In case of calcified lesion, particularly in the iliac ostium, the balloon expandable is the best. External iliac artery self-expandable stent more appropriate. Covered stent provide greater durability compared bare metal stent. Avoid spot stenting, instead cover anterior lesion. Hybrid technique, long-term patency, 𝗖𝗋 of iliac and aorta. And if we have iliac occlusion with aortic aneurysm not currently work to treatment, we use balloon expandable stent to ensure future graft delivery. Thank you.